You guys are? All right. Hi, everyone. I'm Dr. Lamb. I'm a second year emergency medicine resident at Freeman Hospital, and I'm going to be talking to you about hemorrhage and trauma today. I know there's a couple other lectures throughout this series that are somewhat similar to this, and I'm sure you guys have all seen more than a few bleeding patients throughout your careers, so most likely a lot of this is just going to be kind of a recap for you. Uh, yeah. So a brief overview of traumatic hemorrhage. This is a super expansive topic. There's a ton of nuance in how to deal with hemorrhages, and every bleed is going to require somewhat different management depending on what's going on. I'm really kind of sticking to the basics here. Didn't want to dive too deep into hemorrhagic shock and DIC and all the other different complications that can occur. Severe hemorrhage has a 30 to 40% mortality rate, and it carries with it the highest risk of death among patients who have experienced a traumatic injury. About 50% of deaths from traumatic injury occur secondary to patients that have had a significant hemorrhage. Um, it's almost impossible to talk about hemorrhage and trauma without also talking about shock. They're almost one and the same. There's a lot of crossover between them. So I will be discussing some hemorrhagic shock in this lecture as well. So a little bit of a 2-for-1 there. Hemorrhage and trauma is a problem because it will contribute to post-resuscitation organ failure if you don't have a lot of blood, even after you have been, stabilized in the ambulance or in the emergency department and transferred to the floor. You're still going to have a number of metabolic deficiencies, anomalies going on that can cause issues down the line throughout your recovery. So hemorrhage has a pretty weak definition overall. Like if you look up a definition for it, all you're going to see is escape of blood from a blood vessel, which is not a very useful definition for those of us working in the medical field. We'll have blood escape if we stick our finger with a needle. That's not a hemorrhage in our terms. And we can't really define it by how much blood we've lost, because a hemorrhage inside the brain may only be a few mLs, but it's still fatal and it's still a hemorrhage. So the medical definition that seems to be most common is the severe or copious loss of blood from a wound. And then shock, which is what the hemorrhage will inevitably lead to if it's not stopped, is a state of circulatory insufficiency that results in low perfusion because pressures drop and the body can't get blood to places where it needs to go, which results in tissue hypoxia, which results in a number of other problems going on, and eventually dysfunction, circulatory collapse, death, etc. The pathophysiology. So an injury happens to the vasculature. It can be any number of things. We all know what makes people bleed. The coagulation cascade is activated. The coagulation cascade itself is an incredibly complex topic all on its own that I have no desire to talk about, and I'm sure no one here wants to listen to all the details of, so I won't. The failure of the coagulation cascade results in continued bleeding, which is sort of obvious. The reduced blood volume results in decreasing perfusion to vital organs and other structures, which results in decreased oxygen delivery, which results in tissue damage, and then cardiovascular collapse, as we just discussed. The body does have compensatory mechanisms to try and make up for all of this blood loss. It's going to have vasoconstriction, so the body will clamp down blood vessels that are not essential for life, mostly involving everything that isn't the brain, lungs, heart, and kidneys to a lesser extent. The heart rate will speed up to try and put out more cardiac output and keep the blood pressure going. You will breathe faster because if you're not getting enough oxygen, your body's going to try and make you pick up your respirations to put more oxygen in. And then you will see a narrowing of the pulse pressure when you take their blood pressure. So the systolic BP might drop, but the diastolic BP will go up because of vasoconstriction. So the gap between systolic and diastolic will actually decrease, which is an indication that a patient might be experiencing shock during initial assessment. Another thing to note here is that in young, healthy individuals, there may be no tachycardia and no hypotension, even with a severe bleed, until late in the course. Young people, especially if they're athletes or in really good shape, can compensate super well for blood loss. So even large internal hemorrhages may be relatively unnoticed until they're just ready to fall over and die. So in patients like that, you need to be more aware and more conscientious of things that could be going on, even if the vitals look relatively normal. So the lethal triad is something that's discussed in a lot of textbooks regarding hemorrhage. Essentially, it's a cycle of things that all co-occur during large volume blood loss that exacerbate each other and result in death at some point. So the blood loss causes tissue hypoxia, as we've discussed. The tissue hypoxia creates lactic acid. If the muscles or other organ structures don't have enough oxygen to meet their metabolic demands, they will create lactic acid. The lactic acid leads to acidosis. Acidosis will make coagulation more difficult. It'll interfere with the cascade, platelets, etc. The poor coagulation causes more blood loss, which makes the bleeding worse. And then the loss of blood will also decrease your temperature, which also impacts the circulation and coagulation function. And as you can see here, we kind of have a feedback loop going on. One makes the other worse, which makes the other worse, which makes the other worse, and this will just keep going and going and going until it's intervened on. And if it's not intervened on, it'll lead to a pathology called disseminated intravascular coagulation, which is definitely fatal, organ failure, and death. So traumatic injuries themselves, broken down into two very broad categories, blunt and penetrating. With blunt injuries, you have MVAs, assaults, most assaults, machinery accidents, falls, and any number of other things that can occur under that banner. With penetrating, you have gunshots, stabbings, impalements, etc. Broken bones are going to be more likely injuries in blunt traumas, and broken bones can actually hemorrhage quite a lot of blood internally, even if there's no displacement through the skin. You can also have organ ruptures and lacerations. Lacerations to the liver and spleen are really common in car crashes, and you can lose up to about 2 liters of blood in that anatomical location from those kind of injuries. Then with penetrating injuries, you're more likely to get those direct vascular injuries, damage to very large blood vessels, arteries. You can also have perforations of the organs themselves. The gunshots also have more issues with potential cavitation injuries. Trajectory can cause wounds and injuries in places that aren't readily obvious given the location. So a lot of different things to keep in mind whenever we're assessing these people initially. This is just a little information on how much blood you can lose depending on the location of an injury. One thing to keep note of here is pelvic and femur fractures. So the pelvis can hold 3,000 or more mLs of blood. The human body has like 5 to 6 liters of blood total on average. You can bleed out almost the entire volume of your body into your pelvis if it has an open fracture. Femurs, it's like 500 to mLs to 2 liters of blood, give or take. Some sources go up to 3 liters, which again is more than half of your total blood volume. Retroperitoneal hematomas, which might not be immediately obvious on examination, can hold up to 4 liters. A massive hemothorax, so a perfed lung, something damaged in the chest cavity, you can lose over 1,500 mLs in there. Intra-abdominal injuries, you can bleed your whole self out into your abdomen too. Intertrochanteric fractures can lose a couple liters. Proximal femurs, a couple liters. Really, the only fractures that are really low risk for insignificant hemorrhage are going to be the tibia, lower leg, and then the arms. Those fractures, they can still cause pretty considerable blood loss internally, but with those, you're really more worried about possible compartment syndrome from bleeding into that compartment as opposed to actual death from the hemorrhage. For assessing these patients, so you get on scene, there's been a trauma. What are you looking for here? So the first thing is going to be vital signs, their blood pressure, their pulse, their temp, their pallor, etc. Is the blood pressure low, pulse high? Is their temp low? Do they look pale, diaphoretic? Any injured patient that is tachycardic and has skin that's cool to the touch in the extremities is considered to be in shock until proven otherwise. There is also a metric here called the shock index, which is the systolic the pulse rate divided by the systolic blood pressure. And if that number is greater than 0.7, they are likely to be in shock. Additionally, you can use ultrasound to assess these people. I know you guys don't currently have ultrasounds on your vehicles, but I've heard that there are some EMS groups that are getting ultrasounds now to do some assessment for that in the field, fast exams and things along those lines, which is probably really helpful. Fast exams are pretty easy to do, and they can very quickly identify intra-abdominal bleeding. Butterfly ultrasounds are handheld, and they're really not too expensive. I think they're like $2,000 for a brand new one. So, whoever buys your toys, talk to them, see if they want to get you one. It'd be cool to learn. And then the definitive answer to whether or not this patient is bleeding internally is going to come from a CT scan, which is obviously going to happen in the ED. But a lot of the times you don't even need that. Unstable patients that look like they're bleeding internally are probably going for a diagnostic laparoscopy in the surgical suite. So this is about the classes of hemorrhagic shock and the symptoms that you're likely to see. As you can see, you can lose about 15% of your blood volume and have basically nothing change at all physiologically. Your pulse doesn't go up, heart rate doesn't, or blood pressure doesn't go down. Everything looks pretty stable. Mostly the same even for class 2. So 30% of your blood volume, we're looking at like 1.5 liters there. And pretty mild changes overall. You might start seeing some base deficit going on, and you may or may not need a blood transfusion at this point. It's really class 3 where things start to get symptomatic. So if somebody is having a markedly accelerated heart rate, low blood pressure, low pulse pressure, they're breathing fast, and they're having some cognitive alterations, confused, difficulty talking, then they're likely to be experiencing a very significant hemorrhage, up to 40% of their blood volume, maybe more. And these people are going to need blood transfusion for definitive management of the problem, and almost certainly transfer to a surgical operating room too. I seem to have an issue with my slides here. Previous or the next one? That is the next one. Okay. Well, I can talk over the slide.
Traditionally the cat tourniquet.
Yeah.
Some out there have that soft T, and some have the some of our SWAT units have the
for everyone listening, I apologize for the technical issue, but it appears that some of my slides don't have the written content, but that's fine. I can just keep talking over them. So these next few slides are really about how we manage the bleeds once we get to the patient. So first thing you're going to want to do is apply pressure to the wound. You can use gauze and elastic bandage, press the gauze down into whatever wound you're trying to occlude, and then use the elastic bandage or Coban or whatever you have to just clamp it down as tightly as you can to try and keep pressure there. If it continues to bleed, you can also apply pressure to the artery more proximal to the injury itself. So, 2 for 1, apply pressure directly to the wound and try and press down on that artery a little bit to stem the blood flow above it. And all that will help with getting coagulation to sort of kick off and clot up that particular area. The textbooks kind of recommend against directly clamping an artery, even when it's bleeding, unless you can very obviously see it, because you can cause a lot of nerve damage and stuff by digging around in there with a hemostat or something and trying to clamp it off. But if there's a very obviously visible bleeding artery and you have a hemostat handy, that's one quick way to get the bleeding taken care of. Other than that, they also make hemostatic gauze, which I'm sure you guys probably have access to. The most common one is called Quick Clot, and it's impregnated with a material that helps coagulation occur in the wound. So you can also pack these wounds, especially if they're penetrating, with that coagulant gauze, and that will help repair the area. And then Freeman is actually carrying a new hemostatic gauze called Wound Clot, which turns into a gel inside the wound, which is pretty cool. So those are super helpful in these type of scenarios. And then with tourniquets, so tourniquets should be the next step if you can't get the bleeding stopped with just pressure alone. There's a couple risks to go along with tourniquets. Clamping off all the blood flow to an extremity tends to result in tissue death if it's left on a particularly long time. But if the pressure doesn't stop it, then it's more important to get it stopped than not. Additionally, you can cause some nerve injuries with them, etc. And then to apply a tourniquet, it's applied above the level of the injury. They're really only useful for extremity injuries. Obviously, you can't put them on a neck or something, and they don't really work too well for groins and armpits. So this is mostly arms and legs we're talking about here. And then you're going to tighten that tourniquet down until the bleeding stops. Applying tourniquets hurts. The patient's going to scream. They're not going to be happy about it, but it has to keep getting tighter and tighter until there's no longer blood flow coming out of that wound. Otherwise, there's no point in putting it on in the first place. And then pelvic binders, definitely something that's really important here. As we discussed earlier, the pelvis, you can bleed out essentially your entire blood volume into an open pelvic fracture. And these probably are not placed nearly enough. Really, anyone that has been in a traumatic situation, they don't have an obvious visible injury, but they are hemodynamically unstable. There needs to be significant concern for a pelvic injury that's causing the blood loss. And it is within reason to go ahead and apply a pelvic binder because if they don't have a pelvic injury, you're not going to do anything bad to them by putting it on. And if they do have a pelvic injury, it might save their life. And essentially what this is doing is reducing the fracture. It's going to close that pelvis back on itself. If the patient is conscious, they're going to scream extremely loudly because this is, I can only imagine, an excruciatingly painful experience. But they make both devices, and you can use a sheet. You can take the sheet, tie it around the hips, and then clamp it down with hemostats to keep it tight. Normally, this is best done with 2 people, or you can wrap something around the sheet to try and crank it down like a corkscrew. And then they also make devices specifically for pelvic binding, which they have at Freeman. I don't know if you guys carry them with you or.
No, we don't currently. That's been controversial whether to buy a commercial device or use sheets,
Yeah.
rolls, that sort of thing.
The sheets work fine. At the end of the day, all you're really trying to do is reduce that fracture. So whether you're using a device or a sheet, it'll work the same either way as long as it's applied appropriately. Another thing to note here, and there was originally pictures on this slide to show what I'm talking about, but a lot of pelvic binders get put on incorrectly. People place them either too high up to, at above the level of the iliac crest or below the injury. Down towards the femur. The binder needs to be centered on the greater trochanter. So that lump at the edge of the hip needs to be the center point of your pelvic binder. And then when it's tightened, it should press that pelvis together like it's clamping it inward. Devices. So there should be more than one word on this slide, but Reboa, for those who haven't heard of it, is a balloon that gets placed intra-arterially and then goes up into the aorta, and you inflate the balloon to stop all blood flow below that point. It will just completely cut off all arterial flow under where that balloon is. And these are not very common here in this area. There are some trauma centers where they're being deployed, and I have seen documentaries from places over in Europe where these are even being deployed by EMS in traumatic situations. And then right now, it's really only used for bleeding trauma, at least commonly, but there's currently a lot of ongoing studies that show that these might be useful just in general resuscitation because they increased cerebral venous perfusion pressure. So they increase the blood flow back to the brain. They stop blood flow to areas that really don't need it during a resuscitation or during CPR. And they result in massively improved rates of return of circulation if you're coding somebody. So I expect that over the coming years, we're going to see a lot more research on these devices, and we're going to see them become a lot more common. I don't know if you guys can place arterial lines. Can the paramedics place arterial lines? No? Okay. Well, that's disappointing. So you guys might not be placing them anytime soon, but they are cool, and we'll probably be seeing them more often. Other than the Reboa devices, there's also alligator clamps called croc clamps that are used for like injuries that can't normally be clamped off with a tourniquet, like armpits and groins. Again, there was supposed to be a picture here, but the device tightens down kind of like a C-clamp over the area of injury in that location to try and stop arterial flow. From what I was seeing, these are mostly only used in the military because they're most useful for armpit and groin gunshots and or stabbings, explosion injuries, things like that. But I assume it's probably something that's also carried with EMS crews somewhere. I don't think Freeman has any. So if you see one, just know that's what it's for. So the resuscitation of people that are bleeding, if somebody looks like they are bleeding heavily or if they have symptoms of shock, you need to aggressively resuscitate them. So just start off. You still need to check the airway first because airway, breathing, circulation. Make sure that they're breathing. They're going to die if they're not breathing, even if you can get the bleeding stopped. Then compression, reduction, pelvic binders, etc. So if they have a bleeding wound when you're checking over circulation, try and put pressure on it. You can also do reductions of fractured extremities potentially. So reduction of an extremity can reduce the blood flow coming from it. So if somebody has a displaced femur fracture or something after a traumatic injury, placing it in a splint and trying getting it back in alignment will actually reduce the blood coming from that injury. And then binders, like we already discussed, pelvic binders, tourniquets, all those things, next lines to try and get the bleeding stopped. Once the bleeding is stopped, we need to start the rest of resuscitation. So 2 large bore IVs is standard, looking for 18 gauge or higher so that they can facilitate massive transfusions. Fluid resuscitation. So give about 1 liter of crystalloid fluids if you don't have blood with you. The ATLS manual recommends not to give more than 1.5 liters of fluid resuscitation with crystalloids or normal saline or anything because it can actually dilute the rest of the clotting factors, make the problem worse. They need enough volume to be able to pump blood, but at the end of the day, if what they're missing is blood, then what they need is blood. So they have to get actual blood back in their body, and we want to not dilute that too much with additional fluids. TXA is another thing that is definitely recommended in traumatic bleeding situations. This is a thrombin inhibitor that stops the breakdown of clots that are forming, and studies have shown that it improves death from every single cause in patients that have experienced a trauma if it is given within 3 hours. You initially give 1 gram IV over 10 minutes. And then when they get to the hospital, if you've given the first gram, the hospital will need to give an additional gram over the course of 8 hours. So if you do end up giving TXA, let us know so that we can do the rest of the thing and we don't give another gram over 10 minutes. External rewarming is also really important, as we discussed earlier in that lethal triad. Hypothermia is one of the things that worsens everything else. So if they're cold, warm them up. Try and use warm fluids if you can, blankets. obviously, the assessment that we do necessitates cutting clothes, etc. So we need to try and keep them from getting the hypothermia that we are ushering them towards with our assessment. So throw a blanket on them or any other mechanism you have to keep them from getting too cold. Blood transfusion is what they're going to need. So when they get to the hospital, I guess we'll start that off. If somebody looks like they're hemorrhaging or bleeding a lot, it might be useful to go ahead and let us know and report that they're going to need a blood transfusion or that they might need one, so that we can call down to the blood bank and get that blood moving towards us. And then if somebody's bleeding really bad, then what they're really going to need is an operating room. So once you guys get them to us, we will do what we can and then get the trauma surgeon involved as soon as possible and try and get things definitively fixed. Sources are supposed to be there, but are not there. So Tintinelli's Emergency Medicine, WikiEM, and the ATLS 10th edition manual are the sources that I used for this. Are there any questions from anyone?
We'll give them a few seconds to catch up and see if they have any questions.
All right. How am I on time?
You ready?
Okay.
It's 9:30. We're about 20 seconds. They are about 20 seconds behind us.
Okay.
Good stuff.
Thank you.
The only thing that I see different our protocol compared to what you have on there,
Mhm.
PXA, we've actually moved away from giving it over 10 minutes, and now we're doing it over what, 2 minute time
Yeah.
frame?
I mean,
We
It's
switched
kind of
to a bolus.
yeah,
Yeah.
kind of the military's went that way, so it's something new. I don't
Mhm.
know, just something that really.
yeah, I mean, it makes sense to me. This dosage actually came out of Tintinelli's, but that edition is several years old at this point, so it's probably just new standard.
And ours is just new in the last year, so like the last maybe
We
6
only
months or
switched
so.
this year, probably. There's a Crash 3 trial looked at TXA quite a bit.
Mm-hmm.
And part of the reason why they switched to the bolus is partly because of the military. They don't do a lot of drips in the military, of course, but pre-housing until they get to a fixed facility. But there's always a little bit of nervousness and anxiety about giving a drip. And if you just pull it up and give it a bolus, it usually seems to be less anxiety for the provider and it gets done more often.
Mm-hmm.
So the key takeaway point from that Crash 3 trial was is it works, get it on board.
Yeah.
If the injury's within 3 hours, like
Mhm.
there. So,
Yeah, I found it really fascinating that it improves all-cause mortality. Like it's just kind of wild that death from any cause whatsoever, even not related to the bleeding directly, is improved with TXA.
yeah. Another study about being used in TBI, so it's really trauma given.
Mm-hmm.
Yeah. No questions, but a ton of thank yous.
Oh yeah, no problem. Do I need to fill more time, or did I go too short?
Oh, you're fine.
Okay, cool.
We appreciate you coming in and talking.
Yeah, no problem.